Thank you so much for the energy and the attention that's been in this room today. It's been really amazing to participate in some of these conversations and to watch all of you with such intention, getting in each other's business and figuring out what's going on and trying to make some change. So thank you so much for that. What we're going to do right now is have 3 different people come up and share positive stories about things that have happened for them in the workplace, and just sort of put those stories out there in the room and let you hear them. Without further ado, I would like to welcome Kelly Ma to the stage. Kelly is a social worker. Look at that. Hey, you got your people. Kelly's a social worker at Sir Raymond Memorial Hospital. She's here to share a story of success in supporting vulnerable patients as they navigate through a broken system. Kelly.
So my name is Kelly. I'm a social worker based in the Emerge at Sir Raymond Memorial Hospital. Part of my role is collaborative care social work. So my role is to focus on people that come to the Emerge regularly. So we call them familiar faces. And a lot of it, my job is to work and collaborate with families, patients, support systems in the community and within the hospital on how to develop care management plans for these folks. And I think throughout my work, I've realized there's a huge gap in the system. We don't communicate. We all work. I think we talked in amongst our groups. We talk in silos, and there's a level of expectations that each department does that I think we just assume and don't really check out the story. Well, that's okay. I'll stand. So the story I'm going to share is really around navigating a broken system. So this fellow, I'll call him Mr. V. He's a familiar face. He lives alone with some wraparound services in the community. He's got a diagnosis of chronic pain, opioid use disorder, Parkinson's disease, and osteoarthritis. So he came into my radar because he kept bouncing from home to emerge with failure to thrive, secondary to falls. And soon we realized these falls are related to overusing his narcotics at home to manage pain. Pain because he's really suffering. Whatever pain is that was real to him, he wasn't doing well at home. So he kept coming in. And every time he came in, he wanted to move into assisted living. My goal is to move into assisted living. And every time he saw my face, I remember him telling me, "You're the thorn on my side, get away from me," because we'd be the ones to send him back home. Because we all know to get into assisted living, you have to be connected to home supports. You can't have it, you got to be free of substances. So I think that was a huge challenge. And, we were doing this whole back and forth for a long time. And finally I realized, at some point, part of my role is to collaborate. So, you got to talk with the folks in the community, home health, what is really going on here? And I learned through the home health case manager that was, he did really well when he was sober, away from drugs, but it's really the substance use that's really taken over. So between the home health and I, we decided, okay, well, we need a goal, which is to try to encourage him to get into potentially treatment if he would ever want to reach his goal of getting into assisted living. This went on for a little while, and finally, Mr. V decided he wanted to get into treatment. Yay, but then we hit another barrier where now, because of his quote-unquote high care needs, he's using a walker, he at times can shower, so his Parkinson's, he's got good days and bad days. And that on top of some maybe minor cognitive issues, he was declined of getting into treatment. So now we're stuck in this place of, okay, here's this guy who is doing his best to try to get to assisted living by doing all these things. And the barrier was he wasn't able to access treatment because of his high care needs. So I guess that was a gap that that his community and myself felt was challenging. How do we work around this broken system? And through that, there was really no option for him but to go back home. It's not like he can just sit and wait in the hospital. So I think between his family doctor, myself, home health, his community pharmacist, we all, and the patient himself, we all collaborated on how do we best support you if we couldn't really change the system. And the GP was really kind enough to offer him flexible visits to go see him whenever he needed, if he was in pain, et cetera, et cetera. And I looked him up on the computer system recently, and I haven't actually seen him in a while. So whether or not things have changed in the community, I'm not too sure. But what I do know is his visits he hasn't been coming to the hospital. And if or when he does, the last time I connected with him, he maintained sobriety, but, with some challenges. But I think what I really wanted to hone in on is the fact that there is a growing need, and I think for Mr. V, he was lucky, he was housed, right? And I think that the conversation is a whole different conversation if we're talking about someone who was homeless, who had all these medical issues, using a walker, incontinence, and cognitive impairment. And I think that's the huge gap. How do we support this group of people who don't fit in any one box? And thank God for these shelters, and I don't know how many shelter providers are out there, but I feel like you guys are the ones who have been open in arms to accept some of these folks and open in collaborating that, we can hang on to these people, but let's be creative and have, home supports come in. And thanks for all those home health individuals who are willing to go in to provide that support, that wraparound team, because without that, I don't know how we'd be able to continue doing some of this work. So that's my story. Thanks. I think that was longer than 5 minutes, sorry.
Thanks so much, Kelly. All right, our next storyteller is Kathie Carter. She's the social work practice lead at Delta Hospital, and she's going to talk to us about the value of taking time to meet as an interprofessional team.
Good afternoon, everyone. Before I start my story, I just wanted to thank Alvin Alvarez and the steering committee for this amazing opportunity. My story is entitled The Value of Family Meetings. This is a true story of a patient named Steve and his wife, Karen. It's a story characterized with illness, caregiver distress, loss, and finally, hope. It highlights the vulnerabilities patients and families can experience and the importance of a compassionate response by healthcare providers. At the core of any hospitalization is the interdisciplinary team. These are healthcare providers who have their own experience but come together with a common goal. In this case scenario, physicians, therapists, dietitians, nurses, a spiritual health practitioner, and social work collaborated to promote the medical, physical, social, emotional, and spiritual well-being of a patient and his wife. Steve, recently admitted to hospital, was very ill and frail, and his wife was struggling with his rapid deterioration. One day, Karen agreed to meet with social work, and she explained that her daily observations left her feeling distraught and unheard. The busy nature of the medical unit and the changeover in the staff led her to assume that no one had the time to listen, that no one really cared. I want you to know that my husband is more than just another number. His life matters, she stated. The wife's tone was firm but ready to escalate if necessary. On many occasions, staff had attempted to speak with Karen and answer her questions and concerns. Karen struggled to absorb this information, and her verbal aggressions and accusations made ongoing dialogues very difficult and very time-consuming. Some team members were frustrated, concerned, and even a little fearful of her. Shortly into our visit, Karen pulled out a family picture. A moment in time, perhaps, when Karen and Steve were happy and healthy. Karen showed a gentler side and started to cry. This is the person I want them to see, and as his wife, I need to know what's going on. Karen had a number of valid questions about Steve's medical status, function, and future care needs. Karen listened carefully as I explained that her voice did matter, but that communication on both sides had been challenging. A family meeting was suggested as a way to share information and devise a care plan. When the day of the meeting arrived, Steve was present, but silent in light of his acuity. His eyes remained attentive as the physician reviewed the details of his medical status. The wife asked questions and the team clarified. It is so hard to understand all of this and keep it straight. Karen's armor was softening. She vocalized various complaints about it, and that it was important for us to listen and learn as Karen shared some helpful insights. The patient's prognosis was somewhat guarded, but the wife needed to remain hopeful. He is going to get stronger and walk out of here, Karen affirmed. Sadly, Steve died shortly after our meeting. Karen, who had been the devoted wife and caregiver, the strong and fierce advocate, was now about to become our patient. I can't do this, Karen frantically called the social work office. The day of Steve's death, Karen had managed well, in fact, better than expected. Several days later, with shock and denial no longer her shield, she was yelling and crying inconsolably. My husband is dead, and I feel myself withering away. The more Karen spoke, the more of her despair came through, hinting that maybe her life was no longer worth living. Karen was clearly in crisis, not coping, not knowing where to turn. Karen had no local family, no friends, no community connections for support. She agreed to come to the emergency department. Upon her arrival, a team of healthcare professionals intervened to assess her mental health and safety and provide her with the necessary support. I am thankful for having met Karen and her husband, as well as the ability to share this story with all of you today. Steve and Karen remind us of how overwhelming the healthcare system can be at a time when people are sick, distressed, and alone. The family meeting was successful in that it enabled us to provide a client and family-centered care through an interdisciplinary approach. At the meeting, medical information was shared and discussed with cultural and spiritual sensitivity. All this enabled the team to appropriately identify necessary resources for care planning purposes. Most importantly, that initial family meeting established a platform of communication and trust with the wife, two tools that became essential while supporting Karen through her journey and eventual crisis. I was also reminded about the power of human connection and the need for compassion in the work we do. The idea that we all need to feel connected and cared for in our greatest times of need. In this story, compassion was there when the healthcare providers took time to listen despite the daily challenges and demands of their work. Compassion was there when a nurse set up a cot so Karen could sleep by her husband's side the night of his death. Compassion was there when the emergency physician and a social worker helped Karen through those moments when she felt that she was barely holding on. Compassion was there when the spiritual health provider stayed by Karen's side in ER, a source of strength and a familiar face amongst the chaos. Karen teaches us that compassionate care is not only what we do, but how we do it. And finally, the Dalai Lama tells us that, quote, love and compassion are necessities, not luxuries. Without them, humanity cannot survive. Thank you.
Thank you so much, Kathie. Our third storyteller is Marika Sandra Lee. Marika works in mental health and substance use services, and she's a knowledge exchange leader.
Hi, everyone. For most of you that know me, I rarely read off a script, but I want to honor, this is a story about a colleague, and I want to honor her reviewing these notes and agreeing to have me share this story. So I'm going to read from this a little bit and then try to engage in more of a conversation with you. This is also a true story. Last June, almost a year ago, I ran into a colleague that I hadn't seen for a while. She explained that she's still doing counseling in mental health and substance use services in Fraser Health, and that recently she's been joining a public health nurse in providing outreach services to distribute take-home naloxone kits every month during Check Issue Week. We were adding up the years of service working in Fraser Health, and when we were counting just past 10 years, I noticed her voice tone change. There was a huge sigh that filled in a silent gap. I don't know how much longer I can do this. I just don't feel the passion anymore. And if you hear about any other jobs, let me know. With that, she ran out of the coffee shop and shut the door behind her. Her words were really jarring to me. I don't know how much longer I could do this. It felt like a professional mortal chill had gone down my back. You see, she was someone who was a rock. When things got tough, she was there. She would hold space. She would keep us going. Even without seeing her work firsthand in the last few years, her reputation and her history of exceptional client engagement encouraged and kept us going. A few days later, it was until Friday, when I checked my voicemail, I heard a message from her asking if we could meet up again soon. We made a date for the next day. It was a Saturday. She bravely disclosed that for the first time in her career, she was resenting her job, her supervisor, her teammates, her site, the system, Fraser Health, and most disturbingly for her, she was resenting her clients. Marika, I get frustrated. I keep hearing the same excuses from people. They haven't followed through with even the simplest tasks. Like the other day, I helped this guy. It was the third time I had to fill out a referral form for him. All he had to do was take one piece of paper to his doctor, get a signature, and he couldn't even do that. I scolded him and I shamed him. I said, you must not want it that much. Before she got the word out much, she started tearing up and she looked away from me. He called me a bitch, you know. I've been called that before and have called worse, but this time I took it personally and I was angry. She looked off at a waste can in the corner and she confessed that her last words to that client keep her up at night. Then she looked me straight in the eye and said, you don't know me anymore. I feel like it's taking longer and longer to do less and less. I'm tired before I begin, and why does it matter anyway? Everyone and everything is starting to look the same. I've got nothing left in my tank. She described examples of her distancing herself from her chosen profession, from the work she once loved. It was like a dam had broken and her words were escaping. They were being fueled by self-doubt and self-criticism. She went on to describe her state as one that requires her to press on, to dig deep. And with that declaration, she grabbed her bag, she gestured me to walk with her, to move on, both literally and figuratively. Her honesty evoked a plethora of comparable admissions from healthcare professionals in recent years. And in fact, in a conversation with Gabor during the break, we shared a situation that happened it was about 6 years ago when Dr. Mate came to speak. We had a nurse in one of our sessions who was sharing some of the same frustrations around our system, that there isn't enough time, there's a huge workload, we can't keep up, we don't have the resources to do what we need to do. And I remember his words to her wasn't some kind of strategy, it was more, how is that landing on you? And that started that whole thinking in my mind around this idea about how do we show up in places. The healthcare system's a traumatized system. How do we show up in that trauma? I also think about how self-care and compassion are frequently touted as vital to healthcare providers historically, but why is there so little done to prepare our workforce? Why is there such little demonstrated support currently for this ongoing development? Most essentially, how could a colleague who epitomized compassion to others fall short of turning this compassion inward for herself? When we got closer to our cars, she decided that she possibly should go on a leave, take an LOA, even take vacation time. I asked her if she wanted to stay in touch, and we did. Over the next 3 months, we developed a routine. I'm part of a mindfulness-based stress reduction group and a meditation group. It became our new Sangha. We always had our coffee shop conversations. We were looking for a meditation group actually within healthcare. We couldn't find it in Fraser Health. We actually found a meditation practice among police officers. Believe it or not, there's police forces that actually start their day with a meditation. I noticed more and more, the more that she practiced her meditation and her mindfulness, that the conversations changed. She wasn't comparing herself to who she was or who she wanted to be and why she was always falling short of that. Her conversations changed into why she did the work in the first place, what connected her to her work. I heard words of self-acceptance and self-compassion, even her concerns about talking about herself so much. She used to be quite embarrassed about that and actually quite shameful and say, I'm being so selfish, I'm so self-indulgent about talking about myself. Even that started falling by the wayside. And she expressed phrases and comments about what connected her to a common humanity, what kept us all connected to our work and what we do each day. She's been back to work now for close to 9 months, and she still continues with a practice. In fact, she's been helping me and others develop curriculum and content in our trauma and resiliency informed practice workshops. I know we have colleagues here in the emergency room. That is a whole initiative that's happening. A couple of weeks ago on a surgery unit in Langley Memorial Hospital, with a medical unit, we did a trip workshop and we started with a meditation. I asked her what she wants to leave your final words with all of you today, and they'll resonate with what you heard this morning. This is her message to all of you. And Brooke, you'll recognize these words. Stay curious. I have a beginner's mind, and each day brings something new in my practice that reminds me how I'm connected to this work and to each other.
Thank you so much to all three of you for sharing those stories. Thank you.